Good morning, and thank you for joining our webinar titled The Impact of COVID-19 on Future Higher Age Mortality. My name is Peter Patrician from Prudential Financial of the United States. Thank you all for attending. Our discussion today investigates some of the implications posed by the novel coronavirus that pension leaders, risk managers, actuaries, and academics are trying to understand. We are recording today's session and will make the replay available on Tuesday, May 19th. This will be emailed to you along with the research paper today's presentation is based on. Before we begin, I encourage all of you to use the webinar's chat function on the right-hand side of your screen to ask questions during the presentation. We're saving about 10 to 15 minutes after this is concluded to answer as many as we can. We will not be taking questions over audio. Everyone will be muted for the duration of this recording. Leading the webinar today will be longevity research and modeling experts, Professors Andrew Cairns of Heriot-Watt University and David Blake from Cass Business School in London. We're also joined today by Amy Kessler, Head of Longevity Risk Transfer at Prudential Financial of the United States. Let's get right to today's program. I'll hand it off to David.
Thank you, Pete. A warm welcome from Amy, Andrew, and me, and the rest of the team that put this together. That's Marsha, Pete, Sam, and Marilyn. We have over 700 people registered for this webinar from our connections at LinkedIn and the Longevity Conference Series. And over 500 people have actually tuned in today. So to friends new and old, we all wish you and your family health and safety at this most strange and challenging time in our history. Amy suggested to us, Andrew and me, around about 6 weeks ago, that we should use the lockdown to try and make some sense of how the coronavirus will affect the area that we have all been working on professionally and academically for many, many years now, namely the impact on higher age mortality. The early evidence suggested that while many people survive the virus without any effect, for others, it has devastating consequences. The early evidence also seemed to indicate a link between frailty or comorbidities and the fatalities from coronavirus. So that suggested to us the idea of a way of trying to explain this, that many people might have died in the near future in any case. So that allowed us to develop the accelerated deaths model that Andrew will discuss. So I'm going to invite Andrew to talk for about 50 minutes. Then Amy will have her own comments on the developments since the virus outbreak. We will then have some Q&A and followed by a wrap-up. So Andrew, over to you.
Okay, thank you very much, David. And so thank you for the introduction, and just want to say that what an honor it is to be able to present today on the topic of COVID-19. So just to briefly again run through the agenda for this webinar. So I'll just start off with a little bit of background in terms of the sorts of data that it is that we're using in the modeling work that we've been doing and the questions that we're trying to tackle. I'll then go straight on to talk about this is really the main part of the webinar, which is to talk about the modeling of accelerated deaths and what the impacts are on life expectancies. I'll then spend a few minutes just looking at socioeconomic variations within the data and how does that help us with our other modeling work. I'll then think about observable and direct consequences of the pandemic, so what might we be looking for in 2021. And then there are other things, so-called indirect impacts from the pandemic. And then we'll have a wrap-up and a Q&A. So this slide for England and Wales shows how death rates have varied by age. It was a graphic that was produced by the Office for National Statistics. And it's a typical picture for many countries. So that's England and Wales. You would see something similar for other countries. And the key takeaway here, perhaps, is that most deaths are really occurring above age 50. And then as a sort of second observation, we can see that we have higher mortality rates for males. And it's graphs of this type that gave us the main motivation for focusing in our work on the higher age mortality, so ages 50 and higher. Now, in this presentation, we are also focusing on what might happen to mortality after the pandemic has run its course. What we are not trying to do is to predict the outcome of the pandemic, although we do, of course, draw on relevant data to inform our modelling work. There are many other people who are focusing on the current pandemic and trying to think about control strategies and the overall size of the outcome. Now, in the course of the work, we've been trying to address a number of questions, including the following. So, first of all, what is the relationship between existing comorbidities and frailties and COVID deaths? And this is perhaps the key question and where we're hoping to offer some new insights. Secondly, will there be some material anti-selection or adverse selection in the surviving population? And the thinking here is that in the surviving population, these were, prior to the pandemic, perhaps more healthy on average than those who died. Thirdly, what socioeconomic differences can we detect and model? Fourthly, what will the indirect impacts be, such as survivors carrying impairments like such as kidney disease or kidney damage? And then lastly, might some of the behavioural changes that we have adopted during lockdown, might some of these persist in the long run and be beneficial to people's health? Now, at the current time, there is a huge amount of data flying around, but often the different data sources can conflict to some extent, or at least in terms of precise estimates of particular numbers. And indeed, the pandemic still has a long way to go. There might be second waves, etc. And so there are no really precise numbers at the current time that where we can sort of pin things down. Consequently, what we've tried to do in our modelling work is really to try to keep things very simple in the modelling work, really just to get an initial feel for what the longer term impact of the pandemic might be. So, for example, we use the Gompertz model for all-cause mortality, and we assume a constant mortality improvement rate, again, just to keep things simple. And in the work, most of the presentation and the paper are going to focus on England and Wales mortality. And for that country, or for those two countries, the current predictions are around about 80,000 deaths in the first wave of the epidemic. Now, alongside the sort of total number of deaths, there's arguably some more information that can be quite useful to us, and we will make use of this in the presentation. And that's things like the age profile of those who die, the gender split, and also socioeconomic differences. Now, all of these quantities are sort of relative numbers. So, and these relative numbers should remain relatively stable as the pandemic progresses. Now, this is another key graphic that helped motivate our way of thinking. So this is a graphic that was produced by David Spiegelhalter, and what he did was to compare COVID-19 mortality rates, which is the black dots. So he was comparing these mortality rates, and he's doing it on a logarithmic scale. He's comparing these COVID mortality rates with all-cause mortality, which is the dashed line, and he's picked out the the circles on that line are chosen to match the black dots for the COVID mortality. So we have a key picture where the key takeaway is that COVID mortality runs approximately parallel to the all-cause mortality. And that's for females as well as for males, although the gap is maybe a little bit bigger, but it's very much a similar picture, that you have a relatively straight line on the log scale and a parallel relationship with all-cause mortality. So it's a relationship which might not be exact, but the consistent gap is certainly very striking. So Spiegelhalter's graphic suggested the following informal way to look at COVID mortality. So we've got the COVID mortality rate, and one way to think of this is that it is the product of three quantities. We have the all-cause mortality rate, which is what we looked at on the last slide, or compared those rates. And then in addition, we have the infection rate, or what proportion at age X became infected, and a correction term that we refer to as relative frailty. Now, we will certainly have estimates of COVID mortality, although we have to think carefully about how much underreporting there is, perhaps. And we also know what all-cause mortality, what that rate will be, or what we would expect it to have been in 2020. But we don't know the other two. However, in due course, what I would hope is that there will be significant levels of randomized testing to allow us estimation of the infection rates, and therefore we can back out of these other numbers the relative frailty. Now, if we think back to Spiegelhalter's graphic, then that suggests that the infection rate multiplied by the relative frailty, that does not depend much upon age, but there is perhaps a little bit of dependence on gender. Now, we're initially going to use the term frail here to refer to people who have comorbidities that significantly raise their risk of death. Now, data from many sources point to a strong link between certain comorbidities and deaths from COVID-19. And this graphic here is just one example from the Office for National Statistics. So it's covering comorbidities for those who died from COVID-19. And we can see, if we sort of work our way down, we can see no pre-existing conditions. So these are people who have died, but they had no comorbidities. So they were essentially healthy individuals. But this is only around just a bit above or below 10% in the England and Wales data. So a very small proportion of the population had no comorbidities, whereas much higher proportions had things like ischemic heart disease or respiratory diseases. And this next chart, this is one that also stimulated considerable discussion amongst our small group that were working on this project. And what it shows is that in the earlier stages of the pandemic, it shows the deaths for the top 4 regular causes of death, plus coronavirus or COVID-19. And it's showing deaths during the month of March, and it's comparing the actual deaths, which is the blue line, the actual deaths in March 2020, and it's comparing that with the gold bar, which shows the 5-year average from the previous years for comparison. Now, it shows, what it shows is that the 4 regular causes of death were a little bit below the 5-year average in most cases, and significantly below in one of the cases. Now, it might be that some of that shortfall is due to our 5-year trend, as opposed to simply taking the 5-year average, and maybe a bit of noise as well. So, for example, during the early months of the year, there was generally lower mortality than we were expecting. But the striking feature in this plot is the ischemic heart diseases, where, and it's the fact that the shortfall is really quite substantial, much more of a shortfall compared to some of the other diseases. And this suggests the possibility that at least some of the shortfall in all of these diseases, but particularly ischemic heart diseases, some of this shortfall were actually people who died instead from coronavirus, COVID-19. And this then helps us to think about how COVID-19 deaths might be subdivided. So some people might be people who would otherwise die in 2020, in the current year. Secondly, some might be people with comorbidities who would have otherwise lived for several, if not many years. And then thirdly, there may be some, probably around about 10%, who had no comorbidities. Now, there is a lot of debate over what the balance might be between these groups, but what I would like to stress is that the approach that I'll talk about in a few moments, that our approach can be easily adapted to these different points of view. So we now move on to the accelerated deaths model, and I will motivate this by looking at a typical curve of deaths. So we start with a cohort of, say, 100,000 people, and the curve shows how many people in this cohort die at particular ages in the future. So typically the curve starts at age, this is a cohort initially age 75, the curve gradually rises up, peaks around the sort of late 80s or thereabouts, and then gradually goes into decline, and that's mainly because the cohort is shrinking quite rapidly at that stage. So even though the mortality rates are going up. Now, a key point in our work is to acknowledge the fact that within a given cohort, some people are in relatively good health and some of them are in poor health. And this is at the current time. And people who are currently in poor health will feature more heavily in the early deaths along this cohort curve of deaths, while the healthy people will feature more heavily in the later deaths. We now introduce COVID-19 with its known links to frailty in terms of both age and comorbidities. And just as an extreme example, suppose that 5% of this cohort die early from COVID-19. And the early deaths in these two charts are going to be represented by the grey areas in the two curves of deaths. In the left-hand plot, COVID-19 takes people completely at random and independently of health status. So it's just 5% of all of these deaths at different ages. Whereas in the right-hand plot, COVID-19 deaths feature more heavily amongst people who are less healthy. And in our minds, the right-hand plot much more clearly captures not just the link to frailty in terms of comorbidities, but also the associated link to age noted earlier by Spiegelhalter. So all that remains to us is to decide what the correct shape might be. And of course, this is a big challenge, and it may well take many months or more likely years to resolve what the right shape is for that. So here is a model that now formalizes the ideas in that last plot. What we are trying to do is define what the shape is of the grey area. So first, DA, so up at the top, DA is the curve of deaths before the pandemic by month T and initial age X. And then we introduce this function pi TX. This defines the proportion of people who would have been expected to die in month T but who sadly die immediately from COVID-19. At this early stage, we chose to use just a very simple exponential curve that depends on two parameters, alpha and rho. Alpha is what we call the amplitude. And the interpretation of that is that approximately, and I stress approximately, alpha times the all-cause deaths in 2020 gives the number of COVID deaths. Rho is called the reach, and this is approximately the average years of life lost by a COVID-19 victim. And then lastly, down at the bottom, pi times dA, that governs the shape of the grey area, which counts the COVID-19 victims. And the red area that is left below that is the curve of deaths for those who survive. And this is surviving in the absence of other, and the curve of deaths in the absence of other secondary effects. This is a more specific example, and it's a very extreme scenario that results in 500,000 deaths overall. And it's consistent with the original Imperial College worst case scenario with no lockdown or other measures put in place. And it's an exaggerated scenario just to help you to visualize what's going on within the model. So in this case, out of the original 100,000 in this particular cohort, currently aged 75, out of 100,000, 3,060 die early, and they shift from the grey area into this red bar in month 1. And then we can calculate up here various life expectancies. So the original life expectancy in our Gompertz model, that was 13.14 years. But for the whole cohort, the pandemic reduces, as we would expect, average life expectancy. That gets reduced to 13.04 years. And then for those who survive, those under the red curve, because of the selection effect, their life expectancy rises to 13.45. But remember that, first of all, that this is an extreme scenario, and then secondly, that this is in the absence of other secondary impacts from the pandemic. Just briefly, this slide shows how the reach parameter affects the shape of the grey area of COVID deaths. So if we double rho, then the grey area narrows at the left-hand end, going from reach 2 to reach 4. That narrows at the left-hand end, but it stretches out at the right-hand end. And because the amplitude alpha here is fixed, the size of the grey area remains approximately the same, the total number of deaths. And lastly, for this worst case scenario, we can look at the impact on life expectancies over a range of ages. So on the left, we plot the life expectancy before, which is the black line, and the life expectancy of the survivors, which is the red line. Now, even in this worst case scenario, it really is quite difficult. You can just see the difference, but not much more than that. So what we've done is that on the right, what we're doing is plotting the ratio. So the ratio of the life expectancy of the survivors divided by the life expectancy before the pandemic. And what this shows is that life expectancies rise by about 1% at age 65, and that rises to over 6% at above age 90. So we now move on to a group of more realistic scenarios, and these are built around a more optimistic estimate of 80,000 deaths that takes account of underreporting and also runoff of the current wave of the pandemic. The table shows specific values that we have tried for the amplitude alpha and the reach rho. And in the first 4 cases, A, B, C1, and C2, the first four cases, alpha and rho do not vary by age. And this is really just to begin our exploration of the model. And in scenarios D and E, we do allow alpha to vary by age. And these particular parameters that are in the table, they won't mean much right now, but there's a logistic function that I will introduce later on. But the main purpose of these two scenarios and allowing alpha to vary by age is to allow us to fit our model to registered deaths in England and Wales and also in the US. Now here, what we're looking at is the impact of the different scenarios on life expectancy before and after. So again, we're looking at the ratio of the life expectancy of survivors to life expectancy before the pandemic. And here, the grey line that's sort of roughly in the middle, well, this is our baseline scenario A. And first of all, putting the other scenarios to one side, for this more realistic scenario with 80,000 deaths, we now see that the impact of COVID-19 on the life expectancy of survivors is really quite small. So down here, at age 65, less than 0.2% of an increase in the life expectancy at age 65, gradually rising, and it's still well under a 1% increase at above age 90. In scenario B, which is the thick, the black line, we scale up the amplitude by 50%, and then deaths also increase by 50%. And then in this, for the plot of the ratios, we see that there's a very simple scaling relationship between the two curves. So that this black curve is just an extra 50% in terms of its impact at all ages. And then in scenarios C1 and C2, so instead of having a reach of 4 years as we did in scenario A, we keep COVID deaths at around about 80,000, but we change the reach to either 2 or 8 years. And that's the red dashed line or the orange dashed line. And what we can see is that although the increases in life expectancy are still quite small, they are quite sensitive, particularly at the high ages. They are quite sensitive to the choice of the reach parameter rho. So we do need to properly get a good understanding of what that parameter might be. Now we look in more detail at the age profile of those who've died from COVID-19. So this chart shows deaths in 10-year age groups for England and Wales. So that's the gold bars, and for the US, that's the blue bars. And these are as a proportion of all COVID-19 deaths. And what we can see is that the profile for the two countries is quite different. So compared to England and Wales, the US, the blue bars, has much higher death rates at younger ages. So much higher, the blue is much higher than the yellow in the bottom 3 age groups, and then it flips round, and in proportional terms, England and Wales has a greater proportion of deaths at the very high ages. Now, these differences, well, they might be due to differing infection rates at different ages in the two countries, or it might be related to differences in the healthcare systems, or some combination of these two things and possibly other things. Now, for our model to be able to capture these differences, we need to introduce some age dependency into the amplitude alpha. So that's what we show in this next slide. So we did this, and again, it was done using a very simple model. It's a flexible logistic curve that we use to model the amplitude and allow it to vary by age. So the key points about the logistic curve is that we have an amplitude of alpha 0 at the younger ages, and then it gradually shifts from alpha 0 to alpha 1 at the high ages. Now, for England and Wales, we found that alpha 1 needed to be about double the value of alpha 0. So that means increasing death rates at high ages and decreasing them at lower ages relative to our benchmark scenario A. So in this chart now, here's the results of that. So the gold dots represent the actual deaths in England and Wales in 5-year age groups. And the black line is the corresponding values for the scenario D, the black line. And we can see that scenario D, the black line, compares very favorably with the grey line, which is the original baseline scenario A, where the amplitude was constant. So with some tweaking of the amplitude function using this logistic curve, we've managed to get a very good fit to what we've observed in the England and Wales data. I'm going to move next to look at socioeconomic differences. Now, when we compare socioeconomic groups, we need to factor in the fact that our more deprived areas have significantly higher mortality by age than less deprived areas. So our benchmark is all-cause mortality relative to the least deprived. Now, in England and Wales, the Office for National Statistics, they often subdivide in terms of socioeconomic differences. They often use the index of multiple deprivation, and what they then use that index to subdivide the country into deciles running from group 1, which is the most deprived, to group 10, which is the least deprived. Now in this chart, the grey bars are, and this is from the ONS, the grey bars represent the relative differences, so relative to group 10, what is all-cause mortality in the other deprivation deciles. So we can see that decile 1, the mortality rates are across all ages, it's age standardized. These are about 90% higher than the all-cause mortality in group 10. The blue bars show COVID mortality relative to decile 10. And this headline chart from the ONS suggests that the 3 most deprived deciles have been disproportionately affected by COVID-19. However, there are confounding factors in play. Most particularly, London has experienced by far the highest COVID-19 death rates compared to other regions. But London has also had a disproportionately, it does have a disproportionately high number of deprived areas. And in combination, these two features push up these relative death rates in groups 1, 2, and 3. So what we've done then is to remove not just the London effect, but all regional differences using a simple multiplicative model. And this is the result. The gold bars, so the grey and the blue are the same as before, but the gold bars show the effect of deprivation decile after filtering out the regional effects. And what we can now see is that, particularly on the right, we can now see that the gold bars are relatively similar to all-cause mortality. So say, particularly in group 1, the gold and the grey bars are roughly at the same height. And this is, of course, still relative to decile 10. So instead of the most deprived having disproportionately high mortality, COVID-19 mortality, what we actually see is in the middle that deciles 4 to 9 have disproportionately low mortality, around 10 to 15% lower than we might have expected. Now, stepping back though, that the main conclusion is that variation by deprivation is not hugely different from what we might expect relative to all-cause mortality across these 10 deciles. So we can now refine the possible link that I talked about earlier, the possible link to frailty that we suggested earlier on. Now, originally, COVID mortality age was written down as being proportional to all-cause mortality by age. But our IMD analysis suggests that we could refine this to say that COVID-19 mortality is proportional to all-cause mortality by age and deprivation decile. And a key point here, though, is that on average, people in more deprived areas have poorer health than the less deprived, higher numbers of comorbidities. On average, they are more frail. But we can then perhaps take this a little bit further, because within each decile, some people are more frail than others. So the all-cause mortality rate might not be by decile, as I've written it here, but it could be down to the individual death rate based on individual frailty. And then this then links to our accelerated deaths model. And then just lastly, as a sort of final remark on this, is that it reminds me also of the link between chronological and biological age at the individual level. Now, a slightly different topic is to think ahead and think, well, what sorts of things might we be looking out for in future years' mortality rates? Now, the model that we've been working on would suggest that there would obviously be a peak in 2020 mortality from the pandemic itself, but then the modeling part kicks in and shows and suggests that we might see a dip in mortality in 2021 because of the selection effect, and that would be assuming no further COVID waves, and then followed by reversion to some long-term trend. And in particular, that the size of that dip would very much depend upon the reach parameter rho in the model. But equally, that's sort of an optimistic thing in terms of what we might hope to see, because of course there will be also various bits of noise in next year's data in terms of other factors impacting on annual mortality rates. However, we can see something quite similar to what the model is suggesting when we look at the recent past, if we look at death rates from respiratory diseases. So that's these charts here. So what these charts show are death rates. It's for respiratory diseases from 2001 to 2016. And it's by age group rather, gender, and high or low deprivation. And what we can see is a remarkably synchronized high, low, high pattern in all of the plots, and as highlighted by these ovals in the charts. And that's in 2013, 14, and 15. It's strongest at the high ages and gradually gets a little bit weaker as we go to younger ages. Now, this might be the result of the 2012 to 13 flu, causing the early deaths of people with chronic respiratory disease, and which then leaves a healthier population with lower mortality in 2014. And my final slide before handing over to Amy is to highlight the potential impact, indirect or secondary impacts of the pandemic. So some of those who recovered from being infected from COVID-19 nevertheless have an impairment such as kidney damage, or some have suffered a stroke. Many people who were unaffected by COVID-19 will have missed out on routine cancer screening opportunities, and that might then result in later diagnosis and then subsequently higher death rates. Other people with existing health problems will have experienced delays in getting treatment. Some furloughed staff might go into a downwards health spiral because they're not coping very well with their new status. And then extending that somewhat to the more general economy, an extended economic downturn could result in long-term unemployment, or an increase in that, a substantial increase. And that in turn might result in, or would be associated with, higher mortality, and that would include deaths of despair. Alongside that, companies themselves might speed up their efforts to automate routine jobs, and that's in order to help their companies become more resilient to future pandemics or shocks. And an economic downturn might also impact on medical spending, both in the short and possibly also in the long run, and that might impact on future mortality improvements. But then on the plus side, some of that spending might focus more on research that's into the slowing of ages, because there's some research is showing a link between some treatments for aging as being beneficial for helping patients with COVID-19. And then lastly, behavioral changes. So some of the changes that we've adopted during lockdown, well, some people might see that, well, that's quite a good thing. I'd like to carry on with that sort of lifestyle in future. So they adapt their lifestyles, and that persists with positive health benefits into the future. So I'll now hand over to Amy to round off the presentation.
Thank you, Andrew, and thanks to you and David for collaborating with us in this incredible body of work. Now, many who've tuned in today are days or weeks away from beginning to work with data sets that include the pandemic period. And it doesn't matter whether you're looking at evaluation, tracing exercise, underwriting risk, or funding a scheme. There are going to be three major challenges that everybody faces in picking up a set of data that includes the pandemic period. And the three challenges are how to adjust experience data, how to assess anti-selection risk, and how to address the near-term volatility that we would expect. Now, first, and by the way, the wonderful work that Andrew and David have done actually addresses all three of these challenges. First, we clearly need to adjust experience data that's been collected during the pandemic period to avoid misestimating, or importantly, avoid overestimating future mortality rates. And since COVID-19 increases each cohort's mortality by a common multiplicative factor, this factor can be used to normalize the experience data that's collected during the pandemic period. The second challenge is anti-selection risk. And Andrew has shown us how to assess anti-selection risk, if any, in the surviving population. And of course, because we don't yet know what the mortality will be from COVID-19, the framework is flexible. It can not only be applied under a wide range of COVID-19 outcomes, but as shown in the US to UK example, it can also be adapted across different countries. And then finally, the near-term volatility. So we know to expect volatility after an event like this. And Andrew and David have offered an approach to estimating the volatility that might arise through an analysis of past seasonal influenza epidemics. And of course, what we would expect here will be exaggerated as compared to those other periods. So thank you again, Andrew and David, for this wonderful work. David, I'll hand it over to you.
Amy, thank you very much for closing the presentation. I've now got a few questions from the audience and also from some that we've had ourselves. And I'm going to come to you first, Amy, because you spoke last, and this question follows on immediately from what you've just said. And it's, are the transactions in the market continuing? And how should pension schemes and insurers think about transacting today in the light of the presentation and in the light of your three challenges at the end?
It does make sense for pension schemes to proceed. We're seeing many schemes that have worked for years and years on their journey plans and have achieved the high hedge ratios and the high fixed income allocations and the high funded status in advance of this terrible event. And for those pension schemes that are in good shape because of their own hard work and adherence to their disciplined journey plan, what we're seeing is those schemes can afford to continue and are confidently continuing on their way to a lower risk future. There are a couple of reasons why this is working well, why the market is working so well at this time. First of all, the market remains liquid and effective. Second of all, spreads have largely risen in the UK. So for those trying to pursue asset-intensive de-risking transactions like buyouts and buy-ins, spreads have risen, and that has made it actually more cost-effective in some cases for people to do transactions. Third, UK population data is available very, very quickly. It's the gold standard in the world. And so the market is very competitive, and many insurers and reinsurers have already adjusted pricing. And then a key factor here is the level of mortality. So thankfully, mitigation efforts have been effective. Hopefully, mitigation efforts will continue and social distancing will continue even as some lockdowns are lifted. And while the number of deaths that we're seeing and expecting are tragic, we don't see high enough mortality to create material anti-selection in the survivor group. And this research demonstrates that. So without that significant distortion that comes from enough mortality from COVID-19 to create anti-selection in the survivor group, without that distortion, that in and of itself is good reason to continue. And, you know, since volatility and improvements have been on the rise for several years and will now be expected to increase again, anytime volatility and improvements go higher, hedges are more valuable.
Okay, Amy, thank you very much for giving us that assessment of the current state of the longevity risk transfer, the pension risk transfer market in the light of this pandemic. I'm now going to go back to Andrew and ask him about some of the technical issues of the modelling and developments. And I've got a question directly of my own, and then I've got some questions from participants, five questions in total. So Andrew, what might be the next steps in this research, and how might it change as more data become available, especially about the proportionality relationship between mortality and frailty?
Well, so first of all, just as a reminder, the proportionality relationship that we proposed in the presentation is that COVID mortality is equal to or proportional to the product of three components. So first of all, we've got the all-cause mortality or the frailty part, and then that's multiplied by the infection rate, and then thirdly, there's relative frailty, and that the all-cause frailty, the first of those three parts, might be done at the individual level. So that was what we had in the presentation. So we have to think, well, as we move forward in the research, how might we be able to sort of narrow down or pin down these sorts of quantities? So we need to take our time to gather the right data, and also in enough detail to be able to answer these sorts of things. And that includes large-scale testing, as I mentioned before, just to establish the infection rates across the population, but then also to, within the population, there's the different subgroups, be it deprivation groups, urban versus rural, regional effects, as well as also ethnic differences between different groups of the population. So there's all of these sorts of variations there that we need enough randomized testing to be able to be reasonably precise about the infection rates in these different groups. And then when we start to think about the all-cause frailty, we've seen that the COVID mortality is approximately proportional to mortality by both age and deprivation group, and that by extension, this would take into account individual frailty. Now, when we think about this, it's important to keep in mind that people who have one particular comorbidity, perhaps diabetes. Now, these people are not all the same in terms of their actual health. Some are managing the condition and keeping in decent health, but others might be in very poor health and with a shorter life expectancy, and also more susceptible to death from COVID-19. So what we need to be trying to do in the future is to try to get a better understanding of how much variation is there within one particular comorbidity, but then also linking that variation to which individuals died and which individuals actually survived.
All right, thank you for that. I've now got a question from one of our participants, Anthony, who asked, what is the underlying level of comorbidities among the old?
So no, that's a very good question, and the unfortunate thing is that at the moment the published data tends to be quite limited in terms of answering that. So I mean, for example, the ONS data, and that this was one of the very early slides in the presentations, that suggested that around about 88% with had comorbidities below age 70, and then that 88% rose to 93% above age 70. So there's some variation, but it's not a huge amount of variation, at least with these sort of crude age groups. And so you might expect the percentage who do not have comorbidities, that will gradually shrink as you go to very high ages, because almost nobody, say at age 90, is completely free of comorbidities.
Okay, here's a question from Andrew. In the modelling, is there any allowance for COVID-19 survivors having a reduced life expectancy compared with them not actually contracting COVID-19?
So, we discussed this really just quite briefly in the presentation and also in the paper, and the reason is that at the present time there's very little data on how many people are being affected by these impairments and to what extent and how long lasting. Now, there are certainly plenty of stories being reported from hospitals, and you can read about them in the newspapers, but it's the actual numbers of what proportion have survived, and of course it may depend quite a lot on the whether they were in intensive care or whether they were in hospital, or if they were infected but were able to stay at home. So that might have an impact. But at the current time, we just don't have the numbers to be able to say anything concrete. But I think it's very important for us to try to really follow up on all of these people in the future, just to see what these sorts of impacts might be. And of course, it could even be that there are some people who don't know that they have an impairment, but that might turn out that in the longer term something might emerge.
Okay, thank you, Andrew. Another question from Liu. What percentage of COVID-19 deaths would have happened if 2020 were a normal year? I guess that's to do with the size of the spike in the volatility.
Again, this is an important question. It's difficult to answer, but it does link to the reach parameter in our model. So and partly to this, how many deaths, as you say, would have happened in 2020. So that if the reach parameter was relatively small, then quite a large proportion of the deaths would be people that were what people say is at death's door. But if the reach parameter is relatively large, 8, 10, 12 years, then a relatively small proportion would be people who would have otherwise died in 2020. So at the moment, we just really don't know. But that, again, it's in the follow-up after the pandemic, that's what we need to think about.
Okay, and I've got my final question from Jorge. Given the way the disease spreads, my question is, to what extent introducing a spatial element such as urbanization could help to predict the excess mortality better?
So, well, the first thing is we're not, in our work, we're not trying to predict ourselves the level of COVID mortality. But there's a lot of what you're saying in that question, which is relevant for the other parts of the analysis. So the spatial element that you mentioned in particular is related to how we analyze the finer details of the outcome. So what we looked at before, we looked at socioeconomic effects and regional effects and combined the two. So with regions, we've already got a spatial element there, and then you can extend that to, say, urban and rural differences, because you can certainly imagine that there are differences in terms of infection rates in these urban and rural areas. So all of that could definitely be added to the pot. And you can do that in the context of just looking at the final outcome of the pandemic. You can look at a register of those who died and map them to where they lived and which group they belonged to. But as I say, we haven't actually and don't want to look at the spatial modeling in terms of predicting the outcome. There's a lot of other people who are doing fantastic work on the epidemiology side who are trying to do exactly that sort of work, and also predict the outcome of the pandemic.
Well, thank you, Andrew and Amy, for answering those questions. It's now time for me to wrap up. Just to summarize the novelties of our approach. Three things to highlight. First, the COVID deaths seem to be proportional to all-cause mortality. That's a very important starting point. That then led to the idea that deaths were accelerated because of the comorbidities that the older generation in particular that had, and the concentration of deaths amongst the older generation. And we also had the idea that the discovery that patterns in respiratory and seasonal flu might be helpful in predicting the volatility spikes in the case of future COVID pandemics, outbreaks. So just to, again, to remind our listeners, the research paper underlying this will be available from Tuesday, the 19th of May. It'll be on the Pensions Institute website. So you would go to pensions-institute.org/discussion-papers, and you will then see reference to a paper, Pi-2007, and that is where our research paper will be. We'd be very happy to receive responses and feedback on that paper. I'm personally very sorry that as the co-organizer with Andrew of the longevity conferences, that we had to delay the Longevity 16 conference in Singapore and delay it for 1 year till 2021. But we thought we'd keep the momentum going, which is why we decided to host this webinar today. There might be future webinars on this, again, to keep up the momentum. And so we would welcome any suggestions on that in the light of today's presentation or future developments in the market. So I, again, thank everyone who checked in today. And we all wish you that you take care and keep safe. And goodbye for now. See you soon.